Now I'm working with Helms, where he's been for a couple of years. He previously was in Australia and also in Ontario with Orange. So thank you, Michael. We're all really looking forward to your presentation here.
Right. Well, thanks so much. Haven't been in Australia, although I really would like to go. I think the most important thing to say is that so I've gone a little bit full circle in my career. So I actually started as a paramedic and then went into medicine, did work with Orange and the Canadian military and a few other things, and ended up in London now 30 some odd years into my career, which is seems like it's going by fast. I was a little nervous coming up here a few minutes ago because I thought, oh, I'm not the right person to be talking to you about cutting-edge clinical practice when I voted the opposite on every single one of the... But maybe I have to convince you a few things. The last vote, though, it finally went my way, so I have a little bit of courage. So in the next, 30 minutes or so, I'm going to give you at least my perspective and a European perspective, I guess, European until Friday, then maybe not European, perspective on research in, cutting-edge clinical practice. So, as we go ahead here, I'm going to sort of do an ABCDE approach because I thought that's the only way I can kind of organize this big topic, and try to give you a bit of insight into what's happening on our side of the pond and hopefully inform some of the practice here. When we go through this, I may not be able to resist putting in a few comments about the debates and opinions on them, more in the second presentation after lunch on that. But starting with the A's. So in terms of airway management, there's a couple of things to talk about. So in our system, we have, as you'll find out after, the two talks just kind of go in a backwards order, but we have a physician-paramedic team that we use for pre-hospital care there. And we have very set criteria in terms of who we give our pre-hospital anesthetics to. And you'll see in the top left-hand corner of the screen here is sort of the criteria that we use. And we really follow this in terms of our guidance, and you really have to justify whenever you're RSIing someone if you're falling outside of that. But the real big important part of this is cut straight out of our SOP on pre-hospital anesthetic is really about the risk-benefit analysis you have to do on every single case that you RSI, because we recognize anytime you're doing this outside of not even a hospital, but really outside of an anesthetic room or an operating room, whether it's in the ICU or in the emergency department, and certainly in the pre-hospital setting, the risk-benefit balance is different, and it's not quite the same safety in a patient who hasn't been, pre-screened, fasted, had a full assessment. You know exactly what you're walking into. So all those things start to confer benefits, and one of the most important things about, I think, the pre-hospital medicine setting is not deciding to do things, but when deciding not to do things, and having that balance, and that's where the clinical judgment and expertise and experience really comes into play. So I gave a talk yesterday, and one of the things I talked about was some of the data and evidence that led us to our, basically what you'll hear a lot of is a 3-2-1 sort of approach to fentanyl, ketamine, and rocuronium for RSI. One of the slides I didn't show on that is this figure 3 from that same paper. And figure 3 was a small number of patients in this case, and these were mostly head injury type patients, trauma patients that had the RSIs. But we actually see a signal here of decreasing blood pressures. And over the past couple of years, since this new regimen has been in practice both across pretty much all of the UK and most of Europe, we've really started to see a little bit more of this. And this has actually changed or led to a shift in our practice, which is coming in and being sort of fully cemented now. But instead of thinking about 3-2-1 as our primary regimen, now what we're really thinking about is the 1-1-1 as our standard. And then when you have a patient who has a head injury with a high GCS, that's when you sort of go up in your doses and go to a 3-2-1. And when you have the very sick patient who's the multi-trauma, peri-arrest, or someone with a low GCS, we do a 1-1, possibly dropping ketamine if they have a very low GCS and they're in that sort of just pre-arrest. And then we have a separate sort of cocktail for cardiac anesthetics for our post-ROSC patients and more primary cardiac issues, and that's we substitute midazolam for ketamine, and we do a fentanyl, midazolam, rocuronium anesthetic. So this is basically sort of what generally is happening in most places across the pond and where things have been going, but I think you'll see a lot more about this sort of moving to our standard in the next little while. One of the things to be aware of, though, is that we do worry about not emergence reactions, but anesthetic awareness with this. So if you do a lot of procedural sedations with ketamine, you'll certainly find there's times, because there is a wide therapeutic window for this, where you give patients 1 milligram per kilogram for their, or approaching doses of that or that high for procedural sedation, and they're still, having to top them a little more to get them unresponsive. So we're sort of watching this carefully. So in terms of our algorithm, we have a basic sort of standard algorithm for RSI, a very simple approach, but really the thing about this is that it is meticulously followed, and I'll talk a little bit more about the ethos of the service and sort of our approach to practice, but it's basically pre-oxygenation, RSI, 30 seconds into, if you don't have a good view, we start to do drills and to optimize after we've already worked on optimizing first pass, and then we have sort of our backout plan. We always use a checklist for every intubation, and this checklist actually is eventually becomes part of the sort of CRM of the situation, because you can be on the most chaotic scene in the most distressing situation. This is where we start to create that bubble of normalcy around us, which we talk about, where this is where it becomes your moment. And going through this is almost like my Zen moment. You start to see people have the same cadence and canter that they get to reading through the checklist, and you see the doctor paramedic team, the HEMS team sort of working through this, the back and forth as you go down it. And by the time you get to the end of this, you're like, I'm good. Your heart rate's down, you're in a good place, you're on the best part of your performance curve for RSI in this patient, and it's like this, you've done this every day, in and out, and it doesn't matter where you are, what situation you're in, you've just created that normalcy around you. So if we run into difficulties, so this is what we use for about 99% of our patients. We do have a crash checklist, which we use on a very rare occasion. This is for someone who's sort of immediate pre-arrest, but we still use a checklist. And there's times where we argue, actually, the sicker the patient, the more appropriate it is to use a longer checklist. It still takes only about 30 seconds to do the checklist when you run through it, even the long one. But it's those situations where things are going wrong that you actually, and the patient's sickest, that you actually want to do everything possibly in your favor to get it right on your first attempt. And this is just our 30-second drills at the bottom of the checklist, so if you have to refer to them. So this is, so just for those who haven't seen this, it's worth sort of seeing. So really everything that we do is, and actually this has come out after the work we've had in London, but this is the guidelines for the Difficult Airway Society and Intensive Care Society in the UK, guidelines for managing critically ill patients, and really this applies to all of our pre-hospital patients. And they follow the very similar types of things. They recommend the use of a checklist, should be used in all cases. Checklists are almost all the same as ours, and it's not just about having this piece of paper, because there have been studies that looked at it and say if you just have a checklist, a checklist doesn't make a difference. What makes a difference is how this fits into your workflow, your practice, and the team ethos around this checklist, and discussing things, opening up communications like secondary plans, and having people around on the same page so you have that shared situational awareness. They also have a very similar algorithm, and one of the things that is common to their algorithm as well as our practice is really front of neck access, and it's surgical intervention as opposed to percutaneous is the general way to go, and pretty much fully accepted standard now, at least in the UK and Europe. So a couple other things. So I can't talk about sort of leading edge things without mentioning videolaryngoscopy, or VL opposed to DL. This is a debate that we're still having in our service. Many of the other HEMS units across the UK, and certainly in parts of Europe and Scandinavia, have started to introduce VL. And almost always the VL device they're choosing is a device that you can use for both VL and DL. So a non-hyperangulated blade that you can use for direct laryngoscopy if you need to, with the backup of switching to a hyperangulated blade if necessary. Now, this is a study that was done in Finland, and what they did was we have a lot of exchange back and forth between us, but they introduced a new sort of protocol and went from basically being do what you want type of approach to RSI, choose your drugs, choose how you do it. Most people using a stylet and tube, and then moving to what's actually the same protocol that we have, including using bougie on all intubations, 30-second drills, same approach, same drugs, same checklists as us, but using VL as opposed to just direct. And what they found was a significant improvement in their first pass success, going up from around 85% in their pre to 98.2%. I think the big difference is, though, is that this wasn't a single thing. This isn't just adding in VL. This is adding in a whole standardized approach to intubation. So it was VL plus the whole standard RSI package. And that's one of the debates that we have at the moment, because when you have, as I showed yesterday in our slides of our just shy of 8,000 intubations over the past couple of decades, when you have a 99.3% intubation success rate with DL, there's arguments about why to add VL. I do think VL is the way we'll eventually go, but at the moment we're a little bit slow in adopting that compared to some of the other organizations. We also have a slightly different patient population to some of the other organizations, and I think as you get into different body habituses in older patients and more cardiac arrests, VL probably has some added benefits. So that's pretty much a quick update on the A side of things. Moving along quickly to the B, so a couple of things to talk about here that I thought you'd be interested in. One is, in terms of our management of chest trauma, so if you're looking for good information, so this is a great site to go to. So the Royal College of Surgeons of Edinburgh runs the Faculty of Prehospital Emergency Medicine, and they have a ton of resources on their website, including many of these protocols. And this is out of their chest injury protocol. So a couple things to point out. One is that the rates of some of these things are not as high as we sometimes think, but definitely we do see a not insignificant number of tension pneumothorax, especially in patients that are on positive pressure ventilation. So something you have to be prepared to deal with and have to have a system that can really manage. So in their algorithm, they divided into two sort of situations. One is the patient who's got that slowly developing pneumothorax, not on positive pressure ventilation. So this is in the spontaneously breathing patient. And then a decision, a little bit more of a stepwise approach. Sometimes needle decompression, although typically if they actually need decompression, if you're what they call a level 6 provider in the UK, you would go straight to a thoracostomy. If you want to keep them spontaneously breathing, you have to be able to insert a drain. If you do a thoracostomy without it, obviously you have an open pneumothorax, and that's not good if you're spontaneously breathing under negative pressure. So in that case, we would do that. We have a very, very, very select group of patients that this happens in, because at least for our service, where we're really going to the most acute trauma patients, we most commonly RSI and do finger thoracostomies, and they would tend to be bilateral. That is one of the areas that's also changing and sort of feeds into the next set of slides, which is ultrasound. And with the ultrasound world, particularly in terms of chest trauma and diagnosis of pneumothorax, there's a number of papers out there, and I think this is really an area that's still open for debate. So we're just going to be we use ultrasound already for access, but we're just about to be introducing it for other aspects of care this year. One of the challenges is that it's really hard to know exactly where this fits into your management. So certainly if you have the very sick patient who's crashing in front of you and who is hypotensive with multi-system trauma, at least in our view, that's not the patient that you necessarily want to be taking the time to be doing sort of lots of ultrasound on. We know that they need to get significant interventions, they need to get to definitive care, and they neither, usually if you have shock that's not otherwise resolving, they need to have their chest decompressed. This study sort of shows how they would prioritize sort of different aspects, so the lung ultrasound versus fast versus the focus echocardiography. And I think the big take home from this is that we still have a lot of work to do in terms of finding out where this exactly fits into pre-hospital care algorithms, and certainly in the emergency departments in UK, what was sort of something that was always done in terms of fast is also sort of not as commonly done now, and it's finding that right balance for the right patient. So on to C, because I have the most to talk about with this. So I think there's three big challenges that we see in terms of management of these patients at the moment. So the first is non-compressible hemorrhage, because I think, as I'll say, we've really got compressible hemorrhage mostly sorted. The second issue is around the cardiogenic shock and vasoplesio that we're really seeing in these patients. These are patients that we've already stopped the bleeding in, and how do we manage them? And then a little bit about bleeding mimics. And again, some of these things I talked about yesterday, and I didn't realize it was going to be a completely or partially different audience today, so I didn't duplicate some of the stuff that I was saying. So the first thing we obviously always want to do is stop the bleeding, and we are meticulous in terms of what we do. So we do have, and all across the UK, there's access to tourniquets, although the data really shows that there's not a huge role for these. So in terms of overall volume of patients. So when you have a patient who has a bleed that requires one, you definitely need to have it there. But in terms of having that massive impact on saving lives and decreasing mortality from pre-hospital hemorrhage, it's not a huge slice of that population. We do use hemostatic gauze. We are particularly meticulous around things like the basics, pelvic binders, pulling extremities to length and splinting, and then very careful packaging. So the way we move patients when we have a patient on scene in terms of trying to prevent any further clot disruption and handling them after that, warming them of course as well, all that packaging bit we spend a lot of focus on making sure we get that right and really paying attention to some of the basics, even though we're a sexy hem service with jumping out of helicopters and stuff I heard earlier. So you can't forget these basics. We follow this sort of general approach to managing our serious trauma patients, and particularly those in cardiac arrest, and this is European algorithm, but we quickly sort of work our way down through this, obviously not forgetting to rule out medical causes, because we still, even being a primarily trauma service, end up at the usually a few times every couple of months, an RTC that was actually a medical cause. Then once we get down here, it's a matter of, we've tried to compress and stop hemorrhage as best we can, but we get into this sort of area here of looking at, okay, we have to do something to get better control. And at the moment, this is pretty much our only way of doing aortic control, which is a full thoracotomy. The thoracotomies we do are predominantly based and the main patients that we save, or all the patients that we pretty much save, are ones that we find have tamponade when we get in there. We get a rare patient who survives with another type of injury, but really none from the blunt trauma and a sanguination. And aortic compression this way, we're recognizing more and more is not going to be feasible, in part because by the time we get to doing this, the patient is so far down that pathway of dying that this is a little bit too late to be doing much. So a lot of our focus now is really shifting to the endovascular approaches to resuscitation and management, and that's something called Rubella, which you heard about. So resuscitative endovascular blockade of the aorta. It's basically like putting a tourniquet on the inside around the aorta. There's a couple of different areas of the aorta that we focus on. So there's zone 1 and then zone 3. Zone 3 is what we've been doing for the last several years in London, and is really focused on fractures to the pelvis for all those cyclists that we had being run over by lorries and whatnot, and the balloon sits down just above the bifurcation. But we're now moving to zone 1, which is more for managing a lot of these intra-abdominal stab wounds and other things that we see. We just published our data on our experience over the past 4 years with zone 3 Rubella, and basically we've had in that time 12 patients that successfully had Rubella. We had a cluster where they were not able to do it, and this is always because of vascular access. And then we had 2 patients that were interesting because this is a trauma-indicated procedure, but were actually IV drug users that had junctional bleeds from aneurysms. So the analysis mostly focused on the trauma patients. They were all quite sick, and we had a significant number more survivors in the patient group that received Rubella versus the patient group that had that were unable to receive it. But these are obviously apples and oranges, because there's a reason why these people couldn't have vascular access and probably aren't the same population as the other population. But so there's more data that will come out from the UK Rubella trial, which is an adaptive randomized trial but this is sort of the earliest information we have on that. Overall, what we found was that there's 13 successful and 6 failed attempts. That the interesting parts where there definitely is a blood pressure response. Definitely is a blood pressure response in these. So these patients are quite sick. So median systolic blood pressure, not MAP, systolic blood pressure prior to Rubella of 57, post Rubella up to 114. We had no cardiac arrests in our patients who received Rubella, but half of them in the non-Rubella group where it wasn't successful, and we had no sanguinating deaths from patients who received Rubella. We did see a high rate of thromboembectomy or thrombosis in the patients who received Rubella, but that's now part of our routine in-hospital process for screening and doing early embolectomies for these patients. The interesting thing about that is that we're actually understanding now that Rubella really helps with clot formation, which is important for the next part of the talk. So we've just moved to a new catheter where we previously were using embolectomy catheters. This is now a purpose-made catheter for doing Rubella and is much easier and more simple to use. We've just introduced it into our service now, and it's a world of difference. The thing that's nice about this is it allows you, this catheter, you can do zone 1 or zone 3 Rubella. You don't need a big long wire like we used to require for the zone 3 Rubella. It has a few basic features, so a balloon that is a better shape for actually occluding the aorta. It has a proximal port for measuring the arterial pressure above the balloon, and distal to the balloon you can measure it from the cordis, and it has a little bit of a safer tip on the end. So this balloon and our new sort of approach to Rubella actually brings in something we call partial Rubella. And I think this is really the game changer and where things are going to be have an impact here in Canada and in the populations that we are looking at, or that you're looking at now here, potentially for zone 1 Rubella. And basically what you do with partial Rubella is the catheter goes in, balloon goes up, you leave the balloon up for about 8 to 10 minutes, and that's kind of like the old way we used to treat bleeding. So you have something that's bleeding, you put pressure on it, you hold it there for 8 to 10 minutes, then you take it off to see whether there's still bleeding or not. And that's what we do with the partial Rubella. So once we've had a complete occlusion phase, we then start to lower the balloon and start to allow flow past the balloon. Now there's a new catheter coming out that actually will make this even more feasible, because right now we have to do it with the other balloon by manually inflating and deflating the catheter, but you get sort of complete occlusion of the aorta, and then you get, as it goes down, you're sort of dropping it by half mils of fluid, suddenly you get a significant amount of flow. So what they've come up with is this new catheter which has an extra balloon on the outside, and what that balloon there does is that actually creates a channel for blood flow around the balloon, so you can actually more easily control the blood pressure. And what you have basically is regional permissive hypotension. So where you have the balloon here above that, you have good blood pressures going to the heart and the brain. Below that, where the bleeding is, we have permissive hypotension, but still have some flow so you don't have complete ischemic time. Now the people who are really smart and going to make a lot of money from this actually have a little device now that, it's patented, it's soon to be on the market, but it takes the measurements from the pressures above the balloon, the pressures below the balloons. It's got a little microprocessor in it, and it starts to automatically adjust how much flow you have. So it does all the work for you instead of someone sitting there trying to put this balloon up and down. And that, we think, will probably end up being what will allow zone 1 Rubella to be used in retrieval, where patients have to go for a long distance. You have actual possibly even treatment of the bleeding with the thrombosis, and then maintaining regional flow below. Sometimes you can actually even lower the balloon completely once you actually have hemostasis. In the last part, to address the issues with access, and I can't believe that I'm actually saying this because this is going back to the old school days of cut downs, which used to. I thought the Seldinger technique was the best thing that was ever invented because this was always so problematic. But we're actually later on this year going to be starting to reintroduce cut downs for access for our Rubellas into the system, and we're doing this in hospital at the moment in London. So blood. So Ann Weaver, as we talked about earlier, we've moved on to whole blood, or as we like to call it, just can't believe it's not whole blood, but almost whole blood. But we've also noticed that we don't have enough. So this one little box in someone who's sanguinated isn't enough to actually resuscitate them. So we're actually, in the next month, doubling our how much blood we carry with us to be able to work on that. So it's going to be basically 2 liters almost of whole blood that we'll have. This is where I get to make the comment about the last study. So as much as I'm a believer in that whole blood is a good thing, so when it comes to the evidence, there actually is no evidence for blood on board helicopters. So if you want good, high-quality data, the PAMPER trial is actually far superior grade of evidence than on blood. So everything on blood, even the stuff we've done, is all observational trials. You kind of extrapolate it. It's dirty data. A large randomized control trial with the pragmatic design of it is actually far superior evidence than we have for what we're doing at the moment and spending a lot of money doing. So, and then I can give you my other talk later on about resuscitation fluids and why, regular blood does all the things you don't really want to do during a resuscitation. We do early access now, so that's the other thing we've learned, and so we do on-scene central lines, and this is all stuff that we do as part of it. We'll talk about later our team and the way we have our team set up, but we recognize we have to get big access. IOs in particular just don't let us have the volumes that we need getting into these patients to resuscitate these truly nearly sanguinating patients. And then this is of course part of a system. This is basically the picture of what it looks like when I walk into the trauma bay, or one of the trauma bays at the Royal London, and we have a whole process of code red activation, which is our major hemorrhage, not just our major hemorrhage protocol in terms of getting blood accessed, but it does everything in terms of activating a whole system of care inside the hospital. IR available, OR is available, full consultant team there, so it's not the juniors. We delivered consultant-led care in the pre-hospital setting. They get consultant-led care when they get into the hospital. This is about treating a patient who is the sickest patient you have in the region at that time. Moving on to the last thing. So, as I mentioned yesterday, there's a really good article by Kareem Brohi, who's one of my bosses, and we have patients that, although we've stopped the bleeding, and he'll say that a patient hasn't died of a sanguination at the Royal London for the past, I can't remember how many years now, but we still have patients that die of hemorrhage. So they're not dying because they're bleeding, they're dying because we find out, just like we see with sepsis, is that they actually have a heart that doesn't work afterwards. And it's the most frustrating thing to have a patient who you've got good hemorrhage control on, but especially if we've had them in the pre-hospital setting, we've done a thoracotomy, or in the hospital, and you just have this cold heart there that's not going. This is a young person who minutes ago was alive. They've sanguinated. They're in a metabolic mess, and no matter what you do, you just can't get this heart going. And they're also often vasoplegic. We see high inotrope requirements in these patients after they're clearly full. So this is the next biggest step. So as we've worked on addressing bleeding and getting these patients surviving because, or not dying because they're still bleeding, we have this another issue that we're addressing now. And this is really where we're starting to look a lot more at the role of ECMO. So this is actually the Parisian team doing pre-hospital ECMO in patients in cardiac arrest. But as I mentioned yesterday, we've just started pre-hospital ECMO feasibility trial in London. It's focused on cardiac arrest, but we're actually learning from cardiac arrest. The intention is to take this and be able to apply it to trauma and other patients once we have the system up and running. So it's just a step into the world of pre-hospital ECMO, and we're doing it on the jobs we see more often so that we're ready for the big sick patients once we've learned how to do it and get the processes in place. And also in hospitals, clearly is something that we're doing more and more often. The last thing, and this is where it starts to get really sort of out there, cutting edge. So this is from Dr. Tischerman, who we do a lot of work with at Shock Trauma in Boston. So he came up with this protocol and sort of idea: if you have a patient who's bleeding, you get arterial access, you put a Rubella in if you can't, just to stop bleeding other ways. We're not so much looking at SAP, but this is where ECMO would come in for us in these patients in this group. But then we actually really are looking at this. So this is EPR, which is emergency preservation resuscitation. This is freezing the patients. So this is the profound hypothermia that they've been trying in Boston and certainly in the military, and they've done a lot of animal studies on. But this is sort of our next step. It will probably have this is what sort of we're working on the ECMO and everything and all that stuff is working towards, because this is for these patients where we have patients that are really too young to die, that we can't for whatever reason get vascular access onto them. we usually have already done the biggest cut down possible, which is the thoracotomy on them. We have ready access to vessels, and moving on to this as a step is something that Gareth Davies and Sam see us doing in the at some point in the not too distant future as an option. So last thing about bleeding mimics, so you've all heard about the hateful eight. We have a slightly different hateful eight, which is what Gareth Davies calls our hateful eight that are signs that a patient's bleeding, but these really aren't always still 100% accurate. So there's definitely patients that we see that have most of these that aren't bleeding. I had one just the other day where I was supervising one of our training doctors, and this patient had all these things. He'd been stabbed multiple times. He looked quite sick. It was middle of the night. Everything was on first blush that he was bleeding, but then we went to pop a line in him, and this 14 gauge just slid right in. I remember when she grabbed his arm and I was holding it, I just saw this nice vein come up, and I thought, oh, this guy's not bleeding. And sure enough, he wasn't actually in them bleeding, but it is really difficult to distinguish these. But what I'm really talking about in terms of bleeding mimics are the patients that aren't bleeding at all. So the ones I talked about yesterday that have had serious head injuries, and we have this whole cohort of patients now that one of the other services have written about, but we certainly have a collection of them at the Royal London as well, who come in, they get code red activations on them, they look like they're major hemorrhage, they've been in multiple trauma, but when we scan them, we find all they have is a significant head injury and nothing else. So this is an increasing group that defies all the old teaching of ATLS and whatnot about head injuries not causing hypotension, but they're exceptionally difficult to distinguish from the other patients, and that's one of our big areas of research and focus at the moment. So moving on to D quickly. So, it can't be a London Air Ambulance talk without talking about impact apnea brain syndrome. Now I've got it right this time, impact brain apnea syndrome. And this is an interesting sort of, again, cluster of patients that we've been starting to see and describe. And the story sort of goes like this in most of these patients. So this is a CT of a patient who was involved in a motorcycle accident and was found to be in cardiac arrest when he arrived on scene. And we had another one of these identical to this the other day. But when you actually scan him, he has no head injury and actually no other real serious other injuries. So difficult to explain why this guy is in cardiac arrest. And when you actually look at this CT of his head, what you just find is profound anoxic brain injury. And this goes back to the old days of many studies where they would see, and there's a whole bunch of animal data to see this, and then more and more descriptions of this in the literature, which is animals, when they have a blow to the head, an impact, they have this period of apnea, and they stay apneic, and they actually maintain their pulse and actually often have a hypertensive response. And then once you start artificial respiration again, they start to then pick up normal respirations on their own. And we see these patients all the time, and if you really take the time to talk to patients, first responders on scene, you'll hear that these people have had blows to the head, and then what happens is that someone opens their airway. They may have some irregular breathing to begin with, or they're not breathing at all. Sometimes people think they're dead. Often they think they're dead. They open their airway, and then they start to breathe again, and you start to see that, and it's not simply just the obstruction of the tongue, and certainly based on the animal data. Why this is important is because these are things that, unless we have the transporter that someone was talking about from Star Trek the other day, yesterday, we're never going to be able to get to these patients with EMS. So this needs a different way to fix these patients, because you need bystanders to actually do this on scene. The other thing that this comes down to and sort of reminds me of is our current approach with the dispatch system and CPR advice that we give to patients. So this is for the zombie apocalypse, but because I couldn't find one for the cardiac arrests on the web last night. But these time and time again recently, I've gone to jobs for traumas where they start to get the CPR advice of, this patient's not breathing. Well, no, because they have impact brain apnea. Start doing chest compressions. But what they really need is they need their airway opened, and they need someone to do some ventilation for them. And so we are seeing more and more of these cases where, trying to talk about the need to probably tweak and refine some of the dispatch advice that's being given for traumas versus non-traumas, exactly the way the ALS guidelines suggest that you need to have a CAB approach for medical patients, but an ABC approach still for traumas. But that seems to be a line that most people skip over when they're reading the ALS guidelines now. So this is really out there. This is Mark Wilson, who's a neurosurgeon and HEMS physician in the UK, now flying with our sister service in KSS. So he's holding the infrascanner, which you saw yesterday or heard a little bit about. And his big thing is, this is more in the retrieval world, but looking at what can we do to actually help people's brains. He talks about the role of pre-hospital and certainly pre-neurosurgery RSIs, or not RSIs, sorry, burr holes being done, just as a temporary measure to try and relieve some of these patients. But the real crux to this comes down to knowing where the blood is. This is where the infrascanner came in. We trialed it in London a couple of years ago, but found a couple of issues with it. One, when you have blood and stuff in your hair and everything matted, we had difficult results. And unfortunately, not a lot of our patients who have serious traumas have nice clean heads of hair after they've had their head injury. The second thing is that we usually have these patients lying down, so trying to get actual occipital access was a bit of a challenge. So Mark's working on this new thing, which is kind of like a bathing cap with all these sensors in it that he pops on patients, and is also looking promising. But once he gets that perfected, that's when he thinks we need to be going down this road possibly. Of interest for you, and again, this is not as directly HEMS, but I think it's really important to be aware of this. But this is the Intensive Care Society and a bunch of other societies' advice on perceived devastating head injury. And this is one of the things that certainly has struck me in England. I've had patients that I thought for sure would never have survived, that I've definitely counseled on limiting care here in Canada, that have made recoveries that I never thought was possible. So this has opened my eyes. So this is their definition of what they call devastating head injury. Basically, it's those ones you look at and you see the CT scan when they come into the hospital and you're like, oh, this is not going to be a good story. So they actually have a protocol now which actually involves keeping these patients on life support and treating them more aggressively than previously has been done. And this is 1 year's outcome from one of the trusts in the south of England that had their first year experience using the new protocol. And the results are quite interesting. So they had 21 patients that went on this protocol. 5 patients actually had their decisions reversed for being DNR, because most of them, they're all made DNR at the beginning of this. 3 of the patients survived, 2 cognitively intact, which is the scary part for me as an intensivist of a long time, and I think about what decisions I may have made in the past. Of the other 16 patients, all died within 48 hours, so it's not a huge burden on resources. End-of-life care they found to be enhanced for all patients, as opposed to just an early withdrawal. And the second thing that was interesting is that 92% of the families consented for possible organ donation of the patients that didn't survive, and a number of them, 5 went on to become actual donors after neurologic death, and 2 after cardiac death. And so they're actually finding that this increases the outcome of organ donation. So all in all, a little bit more aggressive approach to management of neurologic issues can have some positives. Last couple of minutes. So E is not for exposure, it's for everything else that I wanted to just cover here. So a couple of quick things, and I'm wrapping up. So one of the things is so this is called the Good Sam app. This is actually made by Mark Wilson, the neurosurgeon. He did this really as a way to get people to those patients with impact brain apnea, as well as for cardiac arrest. The really interesting thing about this, and the way this is done, this is supported by the Home Office and the government in the UK, but is the introduction of what we call instant on scene. So basically you can send a text message to anybody's phone, they just hit that text message and instantly you have access to their camera. So if you really want to start tasking, and for us in HEMS this is really important to get to the right patients, because we know that the information that we're getting via talking and bystanders on scene who are often quite upset and not able to give the best information isn't always as accurate. I had a job the other day where a patient had jumped off a building and the security guard who went there on scene just said, oh, they found her lying on the floor because nobody saw her jump. And he asked her what was wrong with her, and he said, oh, she's got some blood in her face. This is London on a Friday night. There are so many people that fall and trip and have blood in their face. And the paramedic in our dispatch, are there any other injuries? He said, oh, she's missing a tooth. Okay, that's fine. So the first crew gets there, they immediately call back, send HEMS, patient's pre-arrest, and they realize the patient had jumped off. She had a huge puddle of blood around her head. If you took one look at her breathing, you would have instantly known that she had a massive flail chest. So a picture in that case would have totally changed that dispatch. The The other thing about it is that it has a major incident background to it for your own staff, so you can actually connect with all your own staff, find out where they are, send messages, and all that stuff. So there's multiple different things that this can do, and is being introduced across different aspects of the UK. We've done a lot in terms of unfortunate response to terrorism in the last couple of years, and we recognize that there's an issue with the therapeutic vacuum at the beginning of getting teams in there and getting actual help to patients, and particularly some senior decision making in terms of medical advice on scene for the police and the operations. So Claire Parks is one of our consultants and one of our military physicians. She's been leading on this, and later this year we're going to be having a conference and working on some developing international guidelines. At the moment, a lot of it's still in the world of the secret swirls, so I can't show you anything too much about it, other than to let you know that it's all happening in the background and soon will be made more public. Last two things, and I think this is probably the most important one, so patient follow-up. So we have a patient liaison nurse, and we work very closely to follow up pretty much all of our patients, and that's how you improve your system. So there's two things about it. One is learning the outcomes of patients, because unless you know what actually happens to the patients down the road, you can't understand whether what you're doing is making things better or not. But also for patients themselves, there's podcasts out there, a number that we just released a couple of weeks ago of patients sharing their experience. We do a lot of peer support with patients and have resources for our patients. So even though we're a very upfront service, Frank goes into the hospital, meets with them, works with the hospital staff. They do a lot of signposting and bringing patients and their families back to the helipad, back to meet the crews, and just answering their questions. A lot of times even if the patients died, the families just want to know what happened, and it makes a huge difference for people and if they're surviving or if they're bereaved. Similarly, in terms of learning from death, this is Mike Kim, who's what we call Dr. Death, or the Golden Hour Fellow. So we have a whole program on that's working with our forensic pathologists and with the coroners in London, trying to understand why our patients are dying, because that's the only way we can make things better. And there is a significant lack of information about pre-hospital deaths. Why do these patients actually die, and what could we have done to make it better? So every month, this is Ben Swift, who's a local forensic pathologist. He comes, we sit down, we review all of our cases of patients that we PLE'd or died in prior to arrival at hospital. In hospital, we were able to get more data. And then the last thing is really about taking care of our teams. So I had the chance recently to sit down and have a nice conversation with Prince William, and this is around a lot of the work that we've been doing and looking at how we help our team members. So I've been involved with this medical student. We made a couple of videos all about exposure to trauma and sort of operational stress, moral injury, things like that. Call it what you will. But how to really start the conversation with teams and how to take care of each other. And this is one of the big focuses for us at the moment, and what I'm off to this afternoon to speak about tomorrow in Ottawa. And we have a sort of a growing amount of resources out there, but really resources that are targeted directly towards our pre-hospital first responders, and peer support and conversations about making sure that we all stay well. So, and that is all I have for you.